Welcome to Cardiology Section 2. Follow with us as we review infective inflammatory heart disorders.
So pericarditis, it's inflammation of the pericardial sac that surrounds the heart. They often have chest pain increased with inspiration or recumbency. Sometimes neoplastic pericarditis is painless, but they're going to give you a painful one. And what they're going to say is that the patient lays flat and feels smothered when they lean forward, they feel better, or they have less chest pain. So laying flat is worse, leaning forward is better. They'll have ST elevations in almost all of the leads. So it won't be like, it'll be lead 2, 3, AVF, lead 1 through V6, all of them will have these ST elevations. All of the leads being elevated, it's called pericarditis. Viral is the most common cause. If it's a young female, think lupus. If it's after a heart attack, then it's called Dressler syndrome. So a patient comes in, they have acute heart attack. 2 weeks later, they complain of laying flat. They feel smothered, or they have worsening chest pain when they take a deep breath. When they lean forward, they feel better. EKG shows diffuse ST elevations in all leads. This is called pericarditis after a heart attack, or Dressler syndrome. The treatment for pericarditis is just non-steroidal anti-inflammatories. If it's severe, we use steroids. The big thing about pericarditis or any kind of inflammation is inflammation means that fluid is going to be drawn to that area because it's going to get swollen. So fluid getting drawn into the pericardial sac will cause a pericardial effusion. A pericardial effusion that gets so much fluid in between the pericardial sac and the heart leads to a tamponade. So these are all causes of pericarditis. Viral is the most common thing. Lupus, an autoimmune, radiation. The drug that most commonly causes pericarditis that you should know is hydralazine. Hydralazine causes a lupus-like syndrome, and it can also cause pericarditis. Certain bacterial infections can do it. Acute renal failure, end-stage renal disease commonly causes pericarditis. Rheumatic fever will cause pericarditis, and then cancers can do it. Remember, Dressler's is after a heart attack. This is diffuse ST elevation. Normally the baseline is right here. So this should have came to here, went like this, and then came up and came back down. Instead it raised above the baseline. That's called the ST elevation right there. And then the T wave. Aortic dissection. So it's important to notice the difference between the dissection and an aneurysm. An aneurysm can lead to a dissection, and an aortic dissection can actually lead to an aortic aneurysm. A dissection, though, is only one layer of the artery lining. So there's 3 layers in the artery. It's the inner lining, the intimal lining gets torn, and that leads to an aortic dissection. If an aortic dissection tears through all 3 layers of the artery, that patient will die in about a minute, because that's about how long it takes to pump your blood through your entire body, through the heart, and through your entire system. So somebody who gets an acute torn aortic dissection, it tears all the way through, these people live for about a minute. So the case you're going to get is going to be an aortic dissection where it just ripped through that intimal lining but has not torn through the other 2 layers, and it's just created this area of blood that's between the normal lumen and between the intima and the other 2 layers. That blood that gets in there tends to clot, but that's an aortic dissection. So it happens usually between 40 to 80. The most common cause of aortic dissection is actually hypertension. There are a lot of risk factors for it. Pregnancy, cocaine abuse, chronic hypertension, which is the most common cause. Somebody has a bicuspid aortic valve, aortic coarctation, giant cell arteritis, connective tissue diseases. These are all risk factors for aortic dissection. The symptoms are usually a severe tearing sensation into the middle, straight through their back. It's severe right at the very start. The pain is 10 out of 10 right at the start, and it stays 10 out of 10. The test of choice is gold standard aortic angiography, but CT is the first test in the ER. Aortic dissection, we usually think of it happening in the chest, around the aortic root and on its way down, where we think of the aortic aneurysm more in the belly, the AAA. They happen in both, but typically aortic dissection, we think of it tearing from the aortic root around, so they get the tearing chest pain in the chest, whereas the aortic aneurysm is usually this palpable abdominal mass, and so we'll talk about that one here in a second. So the treatment for aortic dissection is, if it's already ruptured all the way through, then in about a minute these people are probably going to die unless they have just a small leak, and then they're going to have to go in there and actually repair it. So we have 2 types of dissections, type A and type B. A proximal aortic dissection, which is from the aortic root around to the arch, then that's a type A, and they actually have to go in there and surgically repair it. Type B, which is a distal aortic dissection, they just medically management initially and surgery if it's needed. So what we mean by this is type A, about 60-65% of them, it's the ascending aorta. And type B, it's part of the descending aorta, so after the origin of the subclavian. So as you make your arch where the subclavian is, anything down is a type B. So type A, always surgery. Type B, medical. One lining, just the intimal layer. So if it dissects through that one layer and so much blood gets in there, it can actually create an aneurysm as well. These are medications to lower the blood pressure that you can read about. The big one they like to use is nitroprusside, but after 2 or 3 days it can lead to cyanide toxicity because of the metabolite that gets released into the bloodstream. So the aneurysm, peak incidence of 60 years old, it's about 75% of all the aneurysms. It's caused by elastin and collagen degradation. That's why it happens about the age of 60, is about the half-life. So it involves all 3 layers. Unlike the dissection, which is only the 1 layer, it's all 3 layers get ballooned out. So the lumen is normal, it's maybe 1 centimeter, and then everything balloons out to 3 centimeters, the lumen, and then it goes back to 1 centimeter. Or it can balloon out just on one side. So the risk factors are similar to the dissection. COPD because they smoke. Ultrasound is how we diagnose this one because they're typically in the belly. You can use a CT and an MRA to evaluate them, but ultrasound is what you would do if you felt a palpable mass. So the patient's going to present in the ER and you're going to have abdominal pain. You'll do a examination and you'll find a pulsatile mass. If it ruptures, then they end up with back pain, pulsatile mass, and hypotension. This is the classic symptoms of a ruptured aortic aneurysm. Their pain is severe and unrelieved by position. So the the aortic dissection is a severe tearing pain straight through to their back, where the aortic aneurysm is typically a back pain with a pulsatile mass and low blood pressures. Ultrasound is our first line therapy, but you can use the other choices. And then the big thing about the aortic aneurysm, if it's a pulsatile mass without the bleeding, then what do we do about those? So if it's less than 3 centimeters, you don't do anything because it's normal. If the aorta measures 3 to 4.4 centimeters, then we just check it every year. If it's anywhere from 4.5 to 5 centimeters, we refer them to vascular, but they got to do an ultrasound every 6 months. And then if it's under 5.4 centimeters, from 5 to 5.4, then they do the ultrasound every 3 months until they need surgery. By that time, they're already seeing the vascular surgeon. So the number for you to remember is less than 5.4 or 5.5 and higher, surgery. Less than 5.5, no surgery. Observation with ultrasound. Pericardial tamponade. This is where you have fluid between the pericardial sac and the heart. It's called Beck's triad, the symptoms you get. It's called distant heart sounds, distended jugular veins, and decreased arterial pressure. Or muffled heart sounds, JVD, and hypotension. That's another way of saying it. You can get Kussmaul sign, where you get rise in jugular venous pressure when you take a deep breath in. You get a paradoxical pulse. The diagnosis, you must do an echo. With all the other ones, you can do a CT, but you must do an echocardiogram. It's the gold standard for pericardial tamponade. This is because you actually have to see the heart working and moving. In the CT, you'll just do a moment-in-time slice. The echo will actually see the function of the heart actually as it squeezes. You have a pericardial effusion if you just have fluid around the heart. You have a pericardial tamponade if you have fluid around the heart, and then during diastole, the right ventricle collapses. What I mean by this is diastole is when the ventricle should be open and filling with blood, but because there's so much fluid between the pericardial sac and the heart, it crushes the right ventricle because it's usually the weakest of the two, makes it flat so that when in diastole it should be open filling with blood, it stays closed. That defines pericardial tamponade. Diastolic collapse of the right ventricle. So on EKG you can see what's called electrical alternans. On the chest x-ray you can see this huge globular heart. The treatment, you can do either a pericardiocentesis by putting a needle under the xiphoid and point it at the left shoulder and draw the fluid out that way if it's urgent, or you can do a pericardial window. These are done by open heart surgeons, or you can have the cath doctors who do them a lot now. What they'll do is they'll make this little pericardial window. They'll do a 3 flap edge. So instead of making a whole square, all 4 sides, they just do 3 sides. And this makes like a flap so that the fluid, they'll drain it out, and then any excess fluid will drain down into the lung and be absorbed. Pericardial tamponades, so you know, they like to ask the question. Patient comes in with a severe tearing sensation, radiates straight to his back. That tearing sensation is the aortic dissection that tears through the aortic root, and it causes a pericardial effusion. or fluid around the heart, and then that pericardial effusion builds up so rapidly that it causes a pericardial tamponade. So they'll say patient presents with severe tearing pain, radiates straight to their back. They now have muffled heart sounds, JVD, and hypotension. You suspect what? They have a pericardial tamponade because the dissection ripped through caused the pericardial tamponade, and that's what you're seeing now. So remember those kinds of questions. Endocarditis. We diagnose endocarditis with Duke criteria. This is that we'll have a positive blood cultures, and we'll either see we'll see a vegetation on echocardiogram. There's some minor criteria in the Duke criteria, and that's petechiae, splinter hemorrhages, Janeway lesions, ossular nodes, and Roth spots. We'll talk about those. So petechiae are not specific for infective endocarditis, but it's actually the most common thing you'll see. Splinter hemorrhages, you'll see them underneath the fingernail. It's the bacteria in the bloodstream gets distally into the tips of the fingers, and that's where the splinter hemorrhages come from. The Janeway lesions are painless lesions on the hands. Ossular's nodes are painful lesions on the hands. And the Roth spots are the vegetation breaking off and going into the eye. You'll see it on eye exam, ophthalmologic exam. The common pathogens. So acute endocarditis is usually the IV drug user, and it's caused by Staph aureus. Subacute endocarditis is caused by strep viridans, and it's the non-drug user. So the drug user, he sticks a needle in his vein, and the drug gets in his system, and that's how the Staph aureus gets introduced. So Staph aureus and acute endocarditis typically affects the right side of the heart. So it goes to the tricuspid valve, and the tricuspid valve gets in the infection of the bacteria growing on the valve, and then those bacteria can break off and go to the lungs, causing pulmonary septic emboli. So people who have IV drug use endocarditis can come in with a pulmonary abscess and foul-smelling breath, and it's due to IV drug use caused a tricuspid endocarditis that led to these pulmonary vegetations. Where strep viridans commonly affects the aortic and the mitral valve. The antibiotics, we're not talking about a hospital, we're talking about all across the United States or throughout the world. First line is always amoxicillin. If they're penicillin allergic, we use clindamycin. Yes, we will do blood cultures and we will get sensitivities, and once we know our cultures and sensitivities, then we'll use whatever is the appropriate drug therapy, cephalosporins and azithromycin. But amoxicillin is first line treatment for endocarditis, penicillin allergic, clindamycin, and then these are our backups. Often after endocarditis, they need a valve surgery. Something to remember is that if a patient has a stroke and a fever, you should immediately think endocarditis, because what we're talking about here is that a patient has a vegetation on the mitral or the aortic valves. Vegetation breaks off and goes up into the brain, causes the stroke. They'll have the fever from the endocarditis and the vegetation in the brain causing the stroke. Again, Osler's nodes are the painful ones. Janeway are the painless lesions. Roth spots, retinal lesion. The splinter hemorrhages are in the fingernail beds. So endocarditis is the inside lining of the heart. It affects the valves. It does not affect the muscle, does not affect the pericardium. It only affects the inner lining and primarily the valves. Endocarditis prophylaxis, you just need to memorize this now. Over time, I suspect we won't do any prophylaxis, but for now they've changed the criteria, and it's only for prosthetic heart valves, history of endocarditis, unrepaired cyanotic congenital defect, or transplanted heart with some valvular disease left over. Just memorize these. So what we're saying is if you have bicuspid aortic valve, you don't have to prophylax them anymore. If you have an acquired mitral or aortic valve disease, you don't have to prophylax those anymore. Mitral valve prolapse, you don't prophylax. So just these here you have to know. Acute rheumatic fever, what happens is it's an autoimmune response to a person who's had a post-streptococcal infection. It is not the strep that causes the problem. What happens is the strep has DNA markers on it that are similar to our own cardiac markers. So when the body goes and senses that you have the strep infection in your body, it creates an immune response. It starts attacking the strep and labeling it as foreign, and your body starts attacking it and getting rid of it. Well, it turns out that some people have similar markers to the strep, and it goes by the heart and it says, oh, hey, this is foreign. So it starts marking the heart as foreign as well. Acute rheumatic fever affects all layers of the heart, the pericardium, the muscle, and the valves. So all three layers of the heart are affected in acute rheumatic fever. It is an autoimmune response attacking the heart after you got a strep infection. So the strep doesn't attack the heart. The strep causes the immune system to attack it, and then it falsely or incorrectly attacks itself or the heart. So you got major and minor criteria. The major criteria are called the Jones criteria. That's how I remember it, Jones. So it affects the joints, causes a migratory polyarthritis, carditis, which is the O for the heart. It causes the whole myocardium to just get inflamed and swollen. Severe carditis can lead to a severe cardiomyopathy, cardiogenic shock, and you can die from acute rheumatic fever. And for nodules, you get these subcutaneous nodules. The immune complex that gets formed in acute rheumatic fever, they're called Aschoff bodies. You will find them in the heart if you were to biopsy it. It's also found in these subcutaneous nodules. They also get this rash. It's this like snake-like rash or serpingus rash called erythema marginatum. It happens on the chest and the arms. And then they can also get this Sedenheim's chorea, which is a neurologic disturbance where they kind of do this weird snake-like snake charmers dance, and they have no control over it. The minor criteria look like SIRS, just arthralgia, fever, elevated ESR, and they might have a prolonged PR interval. The treatment for acute rheumatic fever is treat the post-streptococcal infection, so penicillin or macrolides for the penicillin allergic. The important thing about acute rheumatic fever is if you get it once, you're going to get it again if you don't prophylax for it, because you're susceptible to it. So what you need to do is if you've had carditis, or when I'm saying you got the acute rheumatic fever, your heart muscle got so swollen you ended up getting myocarditis, you have to actually prophylax this patient with penicillin until they turn 20 or 5 years after the last event. So if they had at the age of 13 acute rheumatic fever, you would prophylax them until they turn 20 years old. Or if they were 17 when they got acute rheumatic fever, then I would prophylax them until they were 22 for 5 years. So if they're under the age of 20, but the time period of 5 goes past 20, that's how long you're going to do it. But if they were 13, then I would just do it until they turn 20, because 13 plus 5 would have only been 18, so I'd still do those 2 extra years. So that's the prophylaxis. You have to use penicillin daily to help protect them. Aschoff bodies actually are pathognomonic for acute rheumatic fever. So if you see the word Aschoff body in the question anywhere, this is what they're talking about. And to know the criteria is you have to have 2 major or 1 major and 2 minor to call it acute rheumatic fever.